everyone. So from the glamorous world of femtosecond assisted cataract surgery, we move into the glamorous world, even more glamorous world of corneal diseases. Yay. So corneal diseases are frequently seen by the general ophthalmologist because anterior segment diseases actually far outweigh all the other diseases in the eye. And if it's involving the cornea, what I feel, although I've been practicing cornea as a subspecialist, but not all cases need to be immediately referred to the specialist because many cases or where people practice, there may not be too many specialists around. So I think that there are simple tools and techniques with which we can manage corneal emergencies also. So our instruction course is nothing but that. In our course, and hopefully we'll have a lot of instructions in the form of videos, we want to provide instructions on very basic surgical procedures with which you can rescue the cornea. So it's like a rescue mission of the cornea. And what I'm very proud of is that we have our younger generation coming in as faculty, and they're going to do all the talking today. So I'd like to invite the first speaker for this session. Before I invite the first speaker, I'd like to invite all the other speakers to come and join me here at the dais at this podium. And the first speaker is Dr. Prajakta Dandekar. Dr. Dandekar has done her cornea fellowship at L.V. Prasad Eye Institute, and she's now working as faculty at Shantilal Sanghvi Eye Institute. Her topic is called Blue to the Rescue. So what is this blue and how does it help you in corneal scraping?
Good morning, everyone. So my topic for today is blue to the rescue. So commonly what we use is gram staining and KOH staining. So I'll be demonstrating how trypan blue also can be used, which is commonly available for any general ophthalmologist. So even if you don't have other stains, you can still diagnose many organisms in it. So showing the incidence of microbial keratitis in the world, it is 2.5 to 799 cases per 1 lakh population per year, out of which UK it is 2.6 to 40.3 and US it is 20 till 27.6, but it is very high in South India and Nepal, where you can see the incidence is 113 in South India per 1 lakh population per year, and in Nepal it is 799. Considering this article given by Tin et al. Showing the most common organism in the region, we see that out of in America, Europe, and some Asian countries, the organism is bacteria, but in India it is fusarium and aspergillus. That is, fungal organisms are more common in our country. This is another article by Charles et al. Showing how fungal keratitis is double that of the bacterial keratitis. Considering this article by Aftab et al., it shows how trauma with vegetative matter is the most common cause of fungal keratitis in our country, and fusarium was a common isolate when the study was conducted in eastern India. This is an article demonstrating how India is the highest for acanthamoeba incidence is highest in India when the study was conducted considering the global epidemiology. Out of which when acanthamoeba cases, they are more contact lens related in other parts of the world. In our country, it is non-contact related acanthamoeba which takes higher prevalence. This is a review article showing Pythium keratitis review, which says that the tropical and subtropical climate like Thailand and in our country, the incidence is more. And the incidence has been shown high in bathing in ponds because of bathing in ponds and agriculture related causes, trauma. So these three organisms like fungi, acanthamoeba and Pythium, which are very predominantly a cause of keratitis in India, this can easily be diagnosed in trypan blue stain is what we are going to demonstrate. So considering these three keratitis pictures, the clinical diagnosis becomes difficult. So that is what the importance of corneal scraping is. So this is an article in which they demonstrated how clinical diagnosis can fail, and because of multiple antimicrobial use also, we are not able to locate clinically what the organism is. So these are different incidents of keratitis in which the clinical predictivity was not very great. Then demonstrating the characteristic features of fungi like serrated margins, dry slough, dry looking ulcer, satellite lesions, which is also, there are also cases reported in which the similar features were present in bacterial keratitis. So again, it is not very specific for fungi. So coming to trypan blue dye, which is used for anterior segment surgeons. For us, we use it for staining the anterior capsule, side ports, main port, also for staining the DM in PK, DALC, and DMEC, DSEC cases. And also, sometimes it is used by glaucoma surgeons to confirm the patency of drainage blips and tubes. In posterior segment surgery, also it was rampantly used for staining the ERM and ILM peeling surgeries. For the first time, Pawan Prashar et al. Demonstrated how KOH and trypan blue, how they can be differentiating the fungal keratitis. So in KOH, he has compared the picture of KOH with that of the trypan blue stained fungi and demonstrated how easily we can pick up the fungi as compared to the KOH, where because of the high line kind of a staining, it is not very prominently picked up. So this is an article by Sharma et al. And group in which they demonstrated even trypan blue can easily differentiate septate and aseptate filaments, which differentiates it from easily from pythium and fungal keratitis. So this is an article by Dr. Somasheila and Varsharati group in which they have compared the trypan blue stain with KOH and chalcofluoride white staining. So they have also demonstrated that it is equally, like the specificity and sensitivity is comparable to each other. And this is a picture showing when the trypan blue was mixed with KOH, it was forming some clumps. And when it is mixed with glycerol, it forms a smooth emulsion, so in which the organism can be easily picked up. So they have recommended trypan blue along with glycerol. The sensitivity again, which was compared with the gold standard, is shown to be comparable with that of the gold standard, even the culture and KOH, chalcofluoride white. So these are the videos. The video is not playing. I'll play it at the end. So showing the trypan blue staining, how it is prepared. So 3 ml of 0.06% trypan blue can be mixed with 0.5 ml of glycerol, and it can be this stain can be used for another 3 days. So normally these are the prerequisites when we take corneal scraping. You have to also assess, you have to keep some slides, then chocolate agar, blood agar, NNA, SDA, PDA, and one liquid media which we used is BHI, brain heart infusion drug. And so paracaine will be used first. There is a marker also placed here, and 15 number blade is the one which we use commonly. So cyanoacrylate glue and BCL also should be kept ready in case if the cornea is very thin. So points to remember for corneal scraping are preferably the medication should be stopped at least 24 hours before scraping. A slit lamp picture or a diagram should be made. The areas of thinning or perforation should be noted before you start scraping. Use dim and diffuse light so that the patient is very comfortable. And the scraping is recommended to be done from the edge and base of the ulcer because that is the area where you can find the organism. Then keep the lashes away from the blade to avoid contamination. So this is how we label the slide. There are a few videos also, I'll demonstrate it at the end. The marking has to be done behind the slide, and you also name the laterality and patient's number or name. And these are the C-shaped streaks which help us to differentiate between contamination and the growth. So any growth which is present in these C streaks is considered, should be taken as significant. So this is a light microscope versus a fluorescence microscope. So light microscope is used for for trypan blue staining, and fluorescence microscope for KOH and CFW staining. So I'll demonstrate few cases in which we found these organisms. So this is a case number 1, 16 years old male patient who is a student who was referred to us for corneal scraping. There was no history of contact lens trauma or steroid use. And the patient had this 6 into 5.5 mm corneal epithelial defect with infiltrate with a streak hypopyon, which is not actually visible in this picture. So it was a dry looking infiltrate with some feathery edges, and you can see there is some kind of a picture like dendrite also in between. And we scrape this lesion, and this is a demonstration in trypan blue staining which is showing septate fungal filaments. So we started the patient on antifungals, and patient is still on follow-up. This is a demo. This is the next patient, 55 years old male from Thane. So he came with a history of trauma with the fingernail. He was unable to remove the contact lens from the eye, which was already removed. So he had a trauma with the nail. Later on, the patient had some patching done at the local ophthalmologist, and there was some antibiotics mixed with sterile water which was given. When the patient came to us, the vision was CF, PR was accurate, and the right eye, the patient had a lesion of 2 into 2 millimeters with epithelial defect with 2 mm of hypopyon.
So, Prajakta, maybe you can just show the positive slide
Yes.
and then go on to the videos because you're out of time actually.
Yes, okay.
So you can just show us the slides instead of this also,
yes.
and then go to the videos.
Okay. So this is a clinical picture of acanthamoeba patient, and this was the how the trypan blue demonstrated acanthamoeba. And this is the latest picture in which the patient has been responding. This is a case number 3 in which the patient had.
Can maybe just go to the videos.
Yes. Okay.
She has videos from her laptop.
So this is the demonstration of trypan blue staining, in which 3 ml of trypan blue is mixed with point. You just place it 1 drop of it and put cover slip on it, and it is seen under 40x magnification. This video is available online. It is along with the article given by Varsha Rathi et al. Just 1 cover slip is placed on the top of it, and you can see it under the light microscope. Then it's not clean. So this is a slide in which the gram staining is being done. The circle which is marked is behind the slide, and a very smooth smear, a very thin smear has to be made for gram staining and trypan blue staining as well. The process is the same. And this is a demonstration of corneal scraping, how it is taken at the edges and the base of the ulcer. It is better to do it unidirectionally to avoid some loss of material. And this is a C-streak demonstration of in any kind of agar plate. So these are the different organisms, fungal, pythium and acanthamoeba, which can be easily seen versus KOH. These are my acknowledgements. Thank you.
Thank you, Prajakta. We will take questions in the end. The second presentation is called Glue to the Rescue. It's on tissue adhesive and bandage contact lenses. It's by Dr. Ikeda Lal. Dr. Lal is unfortunately not able to give the presentation, but she was kind enough to share the talk. And Prajakta, if you can just play the talk from there. The other side. Concept completed. इसके साथ वॉइस है, इसके साथ साउंड है.
हाँ लगी हुई है.
साउंड है इसके साथ. So in that case, I'll just quickly fill in the blanks. So the second talk is about what you had seen, what Prajakta had talked about was, so how do you, what bug do you get, what organism you get, and how simply using trypan blue, which is available for all cataract surgeons, can be an aid to find out what is the organism. So what do we do when we have a patient and there is a lot of corneal thinning in the case of infection, and there's a threatening perforation, there's actually a perforation. So the first technique that I think all of us should know how to do is the use of tissue adhesive and bandaged contact lens.
Tissue adhesives are used as an emergency procedure to salvage the eye in cases to prevent perforation where we have significant corneal thinning and desmetocele, as a preparatory step right before definitive surgery, like at the time of tectonic keratoplasty, to prevent the prolapse of intraocular contents during trephination, and also as an adjunct to sutures. Now there are two different types of tissue adhesives, the synthetic adhesives and the biological. Amongst the synthetic adhesives, the one that we commonly use is the cyanoacrylate glue. It polymerizes rapidly after contact with a wet surface and has high tensile strength. Whereas fibrin glue is usually used under a biological membrane like the amniotic membrane graft, conjunctiva or even corneal tissue, and has relatively lower tensile strength. Cyanoacrylate glue may induce vascularization and inflammation. It's relatively inexpensive and does not need reconstitution, and therefore can be used in both OPD and OR setup. Whereas discussing cyanoacrylate glue and its use. The one that we use here is by the name of amicrylate, which is isoamyl 2-cyanoacrylate. This is a monomer which polymerizes. So here when we open the packet, we have the glue in a vial along with a 1 ml syringe and a needle. So we have to load the glue after breaking the vial into the syringe and needle and then use it. How does the glue work? It interferes with interaction between the newly forming epithelium and the stroma. The epithelium forms under the glue, and that's when the glue becomes loose once the surface is epithelialized. It also has some bacteriostatic action, especially against gram-positive bacteria, and inhibits collagenolysis and stromal melting. Indications for which we use cyanoacrylate glue include patients with corneal perforation, desmetocele or significant corneal thinning more than 70%, patients with Murren's ulcer or PUK to prevent perforation, and also as an adjunct to sutures in patients with corneal tear where we are not able to achieve a watertight closure with sutures alone. Now let's see the use of cyanoacrylate glue for patients with corneal perforation. The size should be between 2 to 3 millimeters, and these could be cases of either infective keratitis, neurotrophic like HSV keratitis, or even dry eye related. The prerequisites include a non-epithelialized dry ocular surface, and we should take care that the glue does not penetrate into the anterior chamber. So let's take a look at this case where we did a TABCL along with AC reformation in the OR setting. So here we are using a Merisel sponge to make sure that we have a dry ocular surface, and then we are using the back of the Merisel sponge to achieve a thin layer of glue and to seal the area of perforation without causing a bumpy appearance of the glue. And then we are using a MVR to enter the anterior chamber. Here I would like to share a case of a patient who was referred to us during the pandemic where there was a paucity of corneal tissues, and we can see that there is a large perforation. She has been on multiple antimicrobial and antifungal agents, and here what we are doing is first using a number 15 blade to take a sample for microbiological analysis, and then we are ensuring that we have a dry ocular surface and then placing a thin layer of the glue. So what we can do here is take the Merisel sponge, dip it in glue, and then press it once more against a sterile surface so that the excess glue comes off and we achieve a thin layer. And then we here notice once we inject a little bit of fluid that there is a leak. So we dry the area of the leak and then apply a little bit more of the cyanoacrylate glue to achieve a watertight closure. And then we are placing an air bubble inside the anterior chamber. Alternatively, a 26 gauge needle can also be used to inject an air bubble in these patients. And then at the end of the procedure, a bandage contact lens has been applied. So this patient was followed up, and this is the first day follow-up picture of the patient. We can see that the tissue adhesive bandage contact lens is in place with an air bubble in the anterior chamber. And after the end of 1 year, we can see that we have a healed corneal scar, and she was taken up for keratoplasty at this point. And this is the first day post-op picture after penetrating keratoplasty. So tissue adhesive bandage contact lens. Now I would like to share these two cases where we have a narrow area of thinning. So the first patient here is a case of neurotrophic keratitis, and we are de-epithelializing the surface before going ahead with application of the cyanoacrylate glue and then drying the surface. And then what we are doing here is using a 26 gauge needle. We have not directly put the glue with the needle but dipped the needle in the glue and then achieved a thin layer of the glue, because this is a narrow area where we need to achieve this kind of a glue effect. So again, in this patient here, when we are using the Mericil sponge in the second case of Murren's ulcer, we were getting a little more glue than we would need. So using a 26 gauge needle, just dipping it in the glue and applying it on the surface works really well in patients like this. Now, post-operatively, we need to put these patients on prophylactic antibiotics and continue the rest of the liquid eye drops. We should avoid gels like the HPMC gel, as they can get stuck on the bandage contact lens, and the bandage contact lens can be changed if needed. The glue should be removed at an average of 4 to 8 weeks, and this duration can be a little longer depending on the size of the perforation, and also in patients with neurotrophic corneas, since the epithelial healing is hampered, we might need to keep this glue for longer duration. Now here I would like to share a case of a patient who has a desmetocele secondary to microbial keratitis and also drug toxicity. So what we did here was that we performed corneal scraping along with cyanoacrylate glue and bandage contact lens application on the slit lamp. And this is after 3 weeks. We can see that the infiltrate has resolved and the scarring is visible under the tissue adhesives. At 6 weeks, the cyanoacrylate glue and bandage contact lens was removed, and we see that the eye has become quiet and the infiltrate has resolved. Over a period of 7 months, her visual acuity slowly improved to 20/100. So cyanoacrylate glue not just helps in preventing perforation, but over a duration of time, these patients might not require definitive surgery. The vision improves, and these can be easily fitted with a RGP contact lens to improve their vision. If we look at the efficacy of cyanoacrylate glue, this study by Setlik et al. Reported that it was effective in treating small corneal perforations less than 3 millimeters, with 40.9% of the eyes healing with the use of adhesive alone without requirement of an additional procedure, and 77. Now, if we look at the complications, the first and foremost is dislodgement of the glue. Second is loss of bandage contact lens, especially if we have an irregular, bumpy appearance of the glue or when we use too much glues. And this tissue adhesive, when bumpy, can cause giant papillary conjunctivitis. Another important aspect to look at is to avoid penetration of the glue into the anterior chamber, as it can lead to toxicity to endothelium as well as the lens. Thank you so much for your kind attention, and once again I would like to thank Dr. Somasheila for letting me be a part of this lovely instruction course.
Thank you very much, Akida. It was a great presentation, and thank you for putting your voice over. So we looked at method of sealing perforations. Now, Dr. Purvasha Narang is going to take us through amniotic membrane transplantation and its various techniques and show us how to seal other such corneal pathology. Dr. Purvasha Narang is Associate Professor at AIMS in Nagpur.
A very good morning to all, and at the outset I would like to thank Dr. Somasheila ma'am and AIOC for allowing me to be part of this course.
So we need to connect the laptop.
They've connected. I am.
So Dr. Purvasha is very happy after successfully managing the cases, which she's going to show us.
Thank you. Sorry for the initial glitch. Okay, so amniotic membrane is something that we as corneal practitioners or ocular surface specialists cannot think away from, and we can't imagine our lives without it. It is basically amniotic membrane, or amnion is basically the innermost layer of the placenta and consists of a thick basement membrane along with an avascular stromal matrix. It has certain biological properties like it helps in the facilitates in the migration of epithelial cells. It helps in the reinforcement of basal cellular adhesion as well as epithelial differentiation, which makes it a very good biological bandage. And certain growth factors and anti-inflammatory factors or anti-fibrotic factors give it an anti-inflammatory, anti-scarring, anti-angiogenic, low immunogenic, and a membrane with enhanced wound healing capacity, along with a certain property of pain reduction. So all these can be the myriad indications of usage of amniotic membrane graft, and not just in ophthalmology or in cornea, but also for sealing macular holes these days, and in other disciplines of medicine like obs-gynae or skin or burns, etc. It is being used. So it is basically in ophthalmology, in the surface diseases, what do we use it as? We can use it as a graft, as an inlay, where as you can see the amniotic membrane with the epithelial side up can be placed in the areas of the tissue loss and allow the epithelium of the surrounding stroma or the normal area to slide over it, and over a period of time it gets integrated into the tissue. It can also be used as an onlay, wherein the stromal side is up and the epithelium beneath it, and the normal epithelium from the surrounding sides is allowed to grow underneath it. And of course, it can be used in a combined manner too. So just for the sake of convenience, I will divide it into the uses of amniotic membrane grafting in acute phases, for in cases of acute burns, acute SJS settings, and for perforations, either impending perforations, desmatoseals, as well as tiny perforations. It can be also used in chronic diseases like persistent epithelial defects, along with chronic cicatricial conjunctivitis like Stevens-Johnson syndrome, ocular cicatricial pemphigoid, for sealing shield ulcer and giant papillae. It can be used as a biological membrane, as a basement membrane, where it is used as an adjunctive procedure in total limbal stem cell deficiency cases like in SLET. Pterygium excision along with conjunctival autografting, if the area is very large, it can be covered over and above the conjunctival autograft with the amniotic membrane. In cases of symblepharon release, dermoid excisions, or even in cases of neoplasia. These days, it is also used as a substrate for ex vivo culture of limbal, corneal, and conjunctival epithelial cells. So how is it available? It's available in the dry or the wet form. The commercially available ones are these. They are dehydrated, lyophilized, sublimated membranes which are present. It can also be mounted over a PMMA ring like this and is sold in the West. However, for us in surface and cornea, we use it as a wet membrane, usually cryopreserved. And this is how it is available over the nitrocellulose paper, draped over that. And this is just to show that the stromal side is up over here, where as soon as you touch the sponge, it sticks to this. So if the epithelial side we touch with the sponge, this will not happen. In case we are having the opportunity to be in a multidisciplinary hospital where placentas are available, we can even harvest our own amniotic membranes from the by separating the chorion amnion membrane and create our own repository of amniotic membranes, which are large like this. And this is the way you can place your nitrocellulose paper underneath it and then cut it as much as you need for the surgery and use it for the reconstructions. So where do we use it? If we can just come over to the acute stages of chemical burns where we see persistent epithelial defects. This is a video which will take us through the actual management of a case of tuna burn where debridement is taking place along with a thorough lavage. And as we see, we are inspecting the fornices for any residual debris. And after this, we have brought up the tenon as in advancement of the tenon is done, and then we place the wet amniotic membrane over here over the entire surface with the epithelial side up. So as we saw here, the epithelium over here is basically up and the stroma is down, and then we have folded it up on one side and placed glue underneath it. The fibrin glue, the thick and the thin components are placed underneath it, and then the amniotic membrane is stuck to the surface. Here we also need to take care that while removing the speculum, it is very pertinent to remove and cut the remnant parts of the glue so that as it might be cohesive with the rest of the membrane, if we are removing the speculum suddenly, the entire membrane will be peeled off. These are the atypical cases of chemical burns where the conjunctiva, cornea, as well as the tarsal conjunctiva need to be draped along with the fibrin glue with the amniotic membrane. So if we have the opportunity to be in a multidisciplinary setup where we see cases of acute SJS, we have the chance to intervene when there is an opportunity window and save the eyes of these patients. Of course, this is a life-threatening condition. We might have to do it at the bedside or somewhere in very non-OR settings. And it can be done under sedation or using one-lint block under all aseptic precautions. We need to trim the eyelashes and close the lid margins and so that the AMG can stick to it. And we have to clear all the necrotic material. Preferably, we need a bigger AMG for each eye, and that has to be draped over the surface into the fornix as well as then reflected over the tarsal conjunctiva as well as the lid margin. So various devices have been invented, and this is the simple infant feeding tube which can be used after cutting it and making it into a ring. And this is a kind of a symblepharon ring, and over which the amniotic membrane can be draped and then pushed into the fornices, and then this amniotic membrane can be unfolded and then stuck to the lid margins. This is another invention by Dr. Bhaskar, where the PMMA rings are used to keep the amniotic membrane together, and this again can be placed in the eyes. In the subacute stages where lid margin is showing signs of keratinization and still the oral mucosa is not healed and you can't do a mucous membrane grafting, we can still use the amniotic membrane over the lid margin and prevent further lid margin keratopathy. In cases of perforations, again, as has been shown in previous videos, cyanoacrylate glue can help, but in cases which are not infected, we can even use the amniotic membrane. And it can also be used in the form of multi-layered amniotic membrane, like I will just show you in this video, where the debridement has been done, and since the tissue loss is quite a lot after debridement, we would like to place one piece, a smaller piece of amniotic membrane with the epithelial side up and glue it after drying up the surface with Wexpel sponge, and then place the other piece just over it, which is larger than the previous one. So this is the first one, and over and above this is, after debriding a larger area of epithelium, this is the area which will take care of the topmost amniotic membrane, and over that the BCL is placed. Again, we are making sure that we cut the glue once it is done. And these are cases of recurrent pterygia which have shown after dissection that there was a lot of limbal stem cell deficiency, and there we have sutured and glued the amniotic membrane and then done a simple limbal epithelial transplantation, and that again helps in rehabilitation of the ocular surface. The OSSN cases, after your removal as well as cryo, you can place the amniotic membrane just so. For cases of ocular surface dryness and in chronic SJS patients where after the PK there is no relief and epithelial defects are persistent, we can use it. We can use it as an adjunct for tenon graft after dermoid excision where the defect is not so large, and in certain end-stage blinding diseases and in painful bullous keratopathy where we are not contemplating an EK. These are some of the contraindications and complications where infections have to be avoided. So it is definitely a boon for the ophthalmologist, and the most commonly used is the wet AMG, and we have to avoid it in active infections, and we have to watch it for the signs of these complications. Thank you so much.
Thank you, Purvasha. Any quick question while Dr. Kavita sets up her presentation? Yes, please.
I have a question of trypan blue staining.
Yeah.
Did you find any increased risk of artifacts as compared to gram staining trypan blue?
Increased risk of?
Artifacts.
Okay. So trypan blue, we can use it only. It will be good only for if it's fungus or acanthamoeba or microsporidia, if you're familiar with how they look like. Whereas on the other hand, it's not so. You cannot use it for bacterial because you're using it under just the mount. It's a mount, and not a true staining of the organisms. So, and of course there will be artifacts. There always are. So this is for the general ophthalmologist. If you see a lot of KOH preparations, there it's so difficult for us as general ophthalmologists to pick up the tiny fungal filaments or the broken fungal filaments which the microbiologists pick up. So this will help that yield, and then we have to be careful, watch out for other things which look like fungal filaments. So they keep on looking at the cases and try to get some experience. So that's the way, yeah. But you're absolutely right. There can be artifacts.
As it states the basement membrane, we know.
Yeah.
There may be chances of epithelial artifacts.
That's right, yeah. The epithelial cells, the basal membrane of epithelial cells, some other fibers. And in trypan blue, there is some junk or muck of the stain itself, which may sometimes may look elongated. So many things may look like fungal filament. Everything looks like fungal filaments. So you have to make sure that the anatomy is exactly as it's supposed to be for fungus, with the septate structure, which has an organized wall and so on. Yeah. Thank you for the question. So Dr. Kavita Rao is a cornea specialist practicing in Mumbai in private practice, and she has a great academic interest in many subjects. She's going to talk about Tenon's patch graft, which will help us and come to the rescue.
Thank you so much, Dr. Somasheila, for having me as part of this IC. So I think the previous speakers have been talking about managing corneal perforations. So corneal perforations have a variety of presentations, and the management, of course, will depend on what the cause is, especially whether the cause is infective, whether it's immune. We have a lot of options: the glue BCL, conjunctival flap, amniotic membranes, and corneal patch grafts or a keratoplasty. Now, where does Tenon's patch graft fit into all of this? The goal, of course, is to have a watertight chamber, and these are the indications for a Tenon's patch graft. So wherever you have any neurotrophic ulcers, herpetic ulcers, or you have immune-mediated diseases like OCP, Stevens-Johnson's, all of these are the indications where Tenon's graft is going to play a role. If there's an active infective component, usually there is no role of Tenon's graft. I'm just saying usually because I'm going to show a case where we have used it in infections also. But typically I would say the most indications would be for immune cases. Now, how how do you decide your case? Obviously, if the the perforation is smaller, it's around 2 millimeters or lesser, a glue BCL works the best. And if it's more than 6 millimeters, then there's no role for any of these, either the amniotic membrane or the tenons. So now the dilemma is when it's going to be between 2 to 5. That's where the dilemma is: do we use an amniotic membrane? Do you use do you use a multi-layered AMG or a tenons graft? So obviously a tenons graft will be better because you don't need to contact the eye bank. It's an autologous harvesting. And also, if you're gluing the patient, then even if it's a smaller, perforation, then you can't put a BCL in cases of OCP. Then again, tenons is going to be superior. So this is a paper by Dr. Sayan Basu where he has, published. I think it's a very good indicator as to how you decide about tenons. So most of the times, if it's a smaller perforation, non-infective, you can see that the glue BCL and tenons both seems to work well, whereas if it's complete sloughing, active microbial infection, then there's no role for your tenons. Now, how does it act? It basically acts by, there is a mechanical plugging which is happening because it's, it's like a volume replacement. You've lost cornea there, and mechanically it's plugging the area of perforation, and also it provides a scaffold over which the surrounding epithelium now migrates. The difference here is that the fibroblasts here, which are coming from your tenons, are different from the corneal fibroblasts. The corneal fibroblasts are more sensitive to inflammation, whereas the tenons fibroblasts have a dampened response to inflammation. I think this is a very important point because that's why I guess the tenons grafts is doing well. This is a histopathology again published by Sayan, where you can see that it's pretty well, you can see that the collagen within the cornea is formed, and then the tenons epithelium is growing over it. This is a very interesting paper published by Dr. Sushmita, which I feel is a little different from what has been published by Dr. Basu. Here, after she's had done a tenons graft, she's done an optical keratoplasty, and here, as you can see, the tenons graft is actually integrated in between, and the corneal stroma has also grown over it. So, which postulates that the tenons also contains autologous fibroblasts, which helps into integrating into the corneal stroma, which I feel is probably can have a paradigm shift in the way we think. Coming to the technique, it's pretty simple. Just running both the videos side by side, you just harvest the tenons, and you can then freshen the edges of your desmetocele, or your if you have like an impending perforation. There are various techniques which have been described for suturing it. I don't know if the panelists they use glue, but I think using a mattress suture has been well described by the LBP faculty who first started doing it, and I think that really works well. Once you freshen the edges, you just put the graft, the tenons graft, and you take the good mattress sutures, and at the end of it you can place a BCL just for comfort if the patient feel it's needed. The other thing is you can always combine it with using the amniotic membrane also. It's not necessary that you'd have to, maybe I'll just forward the video a bit. Oh, sorry. I don't think it allows me to forward, yeah. Yeah, so this is, you can see that the mattress suture out here has been taken, and pretty simple surgically for a cornea surgeon. Now this is a technique where using an amniotic membrane also, this patient again you just have to have, it's kind of like a tuck-in technique where you freshen the edges. I place the tenons first, take the suture, and following that I then put the amniotic membrane, and you can either glue it or take sutures as per your. This is, you can see again the mattress suture I've taken for both of them together, but I think glue also could possibly use. So technique is very easy. It's nothing. It's not really very fancy or difficult. Now these are cases which Dr. Somasheila has kindly shared. This is what I was talking about, in infective, though in most of the literature is describing that it's not to be done in infective, but in this case, they have used it successfully. This is a patient where was diagnosed as HSV keratitis and was on antivirals, and later they found that it was Mycobacterium species on scraping, and this is what the microbiome report of the patient. As you can see, there was mycobacterium found, and patient was started on amikacin 2.5 eye drops. And after the infection being controlled, there was thinning which was seen at around 6 weeks, and then the glue BCL was applied at this visit. And then I think again applied 1 week later, which probably there was sloughing of the glue, and that's when the Tenon's patch was applied. And this was the Tenon's patch 3 months and 1 year post TPG, where the patient then underwent cataract surgery 1 year later, had a good final visual acuity. So so I'm sorry about that slide. So the points from this case was that, it works well in post-infectious cases also, as long as the infection is well under control. So we all know that there is a, inflammation phase which comes in even in an active infection, where there's more lysis happening and not so much infection, especially if you've got the patient under good antibacterial cover. So I guess that's the phase when you can use it, not when there's active infection. Now, Tenon's in this patient obviously did not integrate well and did cause a, like a formed, a dense white scar in the center. So probably maybe, the take home would be that it's not very good for central perfs. So, might as well then use a patch graft. But the other good thing is that they could do a phaco in this case. So that means the tectonic stability is as good as a corneal graft. Now this is another patient with shared by Dr. Somasheila, where 35-year-old male with a trauma a month ago, again microbial keratitis with gram-positive cocaine smears, and TA-BCL with intraocular antibiotic and intense intraocular antibiotic injections was done. And I think all of us have these kind of patients where you keep repeating the glue and the patient keeps perforating and the BCL keeps popping out, and then they've done a Tenon's patch graft and tarsography. And ultimately the patient has done well. This is at post-op 3 weeks, and this is at post-op 2 months. So the take home from this case was that it was combined with cyanoacrylate glue application as an additional layer, and obviously it helped in not having to do a corneal graft, especially a therapeutic graft. It could be avoided, and we can then probably do an optical graft at a later stage as needed. So complications, pretty much I think the most the others seem innocuous. The most I guess the failure of surgery would be a complication where you're having a melt, especially in the immune cases where your graft is also melting away. That would be considered as a complication. Hence, I'd like to summarize that it is a very simple and effective procedure. We don't need any tissue from the eye bank, and obviously it's low cost, and there's decreased risk of vascularization. And also I feel that especially with the fibroblasts being different from corneal, from corneal fibroblasts, less inflammation, there is a long-term potential, especially if you don't have it's not a very central perforation. And then if you've got the scarring, if it's central, you have to do an optical keratoplasty, but otherwise you can get away with managing with rigid contact lenses. Thank you so much for your time.
Thank you. That was a really wonderful, comprehensive presentation.
Thank you.
We'll go to the next speaker. The next speaker is the youngest speaker of this session. Dr. Muscati, thanks for, he's balancing the act in 2 halls, just finished the quiz in 1 hall, I guess. And he's going to speak on corneal patch graft.
Okay, so right away, thanks to Dr. Somasheila and SSEI for help with some of the videos. As you can note from the message, all cases and videos seen in this presentation, except on the title slide and perhaps the last slide, are courtesy Dr. Somasheila. So let's go on with the presentations. The first one is a case of pterygium excision followed by echo, followed by microbial keratitis fungal with perforation and end off, and the plan was a corneal scleral patch, and that was what exactly was done. So in a peripheral area, there are more than 1 ways to skin a cat. Dr. Kavita showed us elegantly the use of a Tenon patch graft. You can also, if you have tissue available, use a cornea there. So important thing is to go beyond the edge, because the edge may be cheesy and difficult to suture. So go a little beyond, use a marking pen, and go a little beyond. Then put your graft, the entire cornea there. Then put it there so that you'll get an idea of how much you need and how much to cut. Err on the side of little larger, because you can always cut it, trim it after that. And sclera, cornea doesn't really matter. They're almost the same once you put it in that area. The idea is to try and save the eye. I don't like continuous sutures, so it's always interrupted in any therapeutic graft, whether it's a central graft or a graft like this, tectonic. Use interrupted sutures. You can open the conjunctiva and go underneath as well, so that you get the full extent. So this was a second case of blunt trauma with a patient who has pre-existing pellucid marginal degeneration with a perforation inferiorly. Patient had already had a tenon patch graft, so then there was nothing else to do except a corneal graft. So again, a whole cornea is being put there so that you can choose the size. Use an old marking pen so that you get nice big marks which will not erase. See that you don't chop off iris at the same time. This is a disposable trifine. You can make two cuts, two different concentric cuts if you like, or you can do freehand. The second cut can be freehand. So I put it on the cornea, then mark it out accordingly, and then put this. You can always trim it afterwards, take a little larger piece. This is Dr. Somasheila's video. Evidently, she's in love with that marking pen.
It's from my colleague.
And then the rest is tailoring. Post-op, this patient actually had 20 by 60. So it's possible to get fairly useful vision if it's in the periphery. This is a patient with Terrien's marginal degeneration, differs from Murren's because it is not painful, but a slight trauma can cause a perforation. This is what happened with an inferior corneal perforation with iris prolapse. So corneal patch graft was planned again. So first you reform the chamber. What do we do with that iris? We can tuck it in because evidently there's no infection. It's not a road traffic accident. If that was so, you would not tuck in an iris. But you can try and tuck it in. You do a small iridectomy there and try and preserve as much of the iris as you can. Again, the same principle. Here you're making the use of remnants of a PK which has been used. So the remaining part of the cornea can be used. So if you are in a high volume center where you have such things, you don't have to sacrifice normal cornea. You can take the remnants from a PK patient. And as I said, if sclera comes along with it, it doesn't really matter. And suture it, open the conjunctiva a little, do a peritomy so that you can suture edges nicely, and you can always trim as required. So this is post-op 18 months with a small cylinder is doing reasonably well with 618 vision. And this is a one-eyed patient, graft versus host disease following bone marrow transplant for sickle cell anemia. To complicate things, because of graft versus host, severe dry eye, and a one-eyed patient. So this is how it was tackled. So again, some things which I keep repeating: open the conjunctiva well beyond the margins of the perforated area. Then you can use a trifine with a marker to mark, or you can use the pen. And Dr. Somasheila uses variety of instruments including iris repositors to mark. take care to preserve as much iris as you can. Not all of us are adept at iris suturing in the second stage with self-created iridodialysis, so avoid that. She is very careful to preserve as much iris as she can. So what suture do you use? 10-0 nylon, 9-0 nylon is what you would prefer. I don't like vicryl sutures as far as this is concerned, and the rest is similar to what I mentioned. Form the chamber afterwards with air so that you know you've got everything, that there are no synechiae there. Push in visco first, wash it out, and then at the end you can put in air. So you're making sure that the chamber is formed in the area where you put the patch graft, that there are no synechiae there. And then air will ensure that that remains a good chamber for at least couple of days before the aqueous takes over. So post-op again, this patient did reasonably well. You could salvage this eye, and the immunosuppression could actually be stopped after a year. And this patient then developed a cataract, which was then operated, and the patient did see well. I have no patients in whom patients saw that well, so I borrowed all the surgical videos from Dr. Somasheila. Thank you so much for your attention. Thank you.
Thank you very much, Dr. Maskati. I think you covered the principles extremely well, much better than I could have, for sure. And yes, we do use that ink in whichever way we can. I think we'll just take up the last presentation first before we try to take in some questions. And the last presentation is by Dr. Suchi Smita. She is a cornea specialist from Pune. So, if there are any questions for Dr. Maskati, we'll take them now. Okay. So Suchi will talk about whatever is remaining from whatever we saved for her to speak about, that is scleral patch graft and synthetic cornea et al.
Thank you, Dr. Somasheila, first of all, for including me in this wonderful and important IC, and good morning, everyone. So I'll be speaking more on scleral patch graft because that's really important as a rescue procedure, and a bit on other methods. So where would we use scleral patch graft? Mostly where the sclera is thinned out or is going into ectasia or staphyloma. We want to preserve the structure of the globe. This can be post any inflammatory cause like a necrotizing scleritis or an infectious scleritis, or more commonly also after surgeries like say post-pterygium surgery or RD surgery. In pterygium surgery, especially if we used MMC, there is avascular necrosis and thinning of the sclera, and rarely also after large cataract sections. So post-trauma as well, after some time we see some amount of thinning in spite of suturing or improper suturing techniques. So in the cornea, the sclera is rarely used nowadays, but like presented by Dr. Maskati in the previous talk, they can be used in the periphery because the sclera is opaque. It can be combined as a corneoscleral graft for peripheral PUKs, and also used for implant extrusion and orbital implants. But most important, I would stress that we must control the inflammation or infection, like in an autoimmune cause, treat the patient with methylprednisolone and all the, the immunomodulators. Otherwise, we will see soon the surrounding areas getting necrosed or thinned out. Although the graft which is put, because it is belonging to another person, the that graft itself does not melt, but the surrounding sclera and the graft edge area can melt. So the source can be, if you have a eye bank where the whole globe is collected, you can even use a fresh sclera, in which case you will clear out all the uveal tissue and clean it with betadine and then use it. Here the sclera is softer and easier to cut. Also as a rim, like earlier explained, most oftenly we use it as a preserved sclera in glycerin or ethanol, and sometimes cryopreserved in ethanol. So patient's own sclera also can be used for very small sized defects. Now this is a case where I use the patient's own sclera. Here just a 1.5 mm wound. Here this is Yamane technique, my initial case, where I accidentally touched the While using the cautery on the haptic of the IOL, I touched the haptic, and so there was a very irregular and sharp tip which got eroded through the conjunctiva eventually. I trimmed the tip and made the bulb again, but in spite of that, it eroded through the conjunctiva. Here, I had to put a small scleral patch graft of the same patient. And the donor site as well as the recipient site should be well covered. Now, this is very important in scleral patch grafts, is that we need to cover the patch graft with conjunctiva or vascularized tissue, because sclera itself is avascular and has a high tendency of not being taken up. So we need to also cover it with tenons whenever we can. In the rare situations where we cannot use conjunctiva, like in this case, there was a lot of conjunctival adherence. This was post-RD case, where it's one-night doctor. She developed a low-grade endophthalmitis. The possible entry of the organism was this thinned out area of the sclera in the periphery. This had to be covered along with the end of treatment. So here we are doing a conjunctival, we are opening up the conjunctiva wherever possible. And now because the sclera is thinned out, it is challenging to suture the sclera to the surrounding the host. So we can make a small pocket like it was shown in the patch grafts in the cornea. Here in the lower left picture, we have made a small pocket all around, lamellar pocket, where we can tuck in the sclera and snugly fit it all around. So the sclera has to be thinned out as much as possible. Preserved sclera tends to be more rigid and maybe difficult to thin out. So you take a bigger graft, as was explained earlier too, because we don't want to use a smaller graft and then realize that it is too small. Two ends can be sutured, and then the remaining part to be, multiple sutures need to be used to make sure that there won't be ectasia again at the edge. Now conjunctiva is used either from the other eye or the same eye wherever possible, and placed and sutured, and an additional amniotic membrane was also placed in this case. So this is the after 6 months picture. So this is a video which I borrowed from Dr. Somasheila. Thank you, ma'am, for the nice video. It was a necrotizing scleritis, where here the necrotic tissue has to be debrided thoroughly, and the conjunctiva is opened up, and after the debridement, the I'll just run through the video. Yeah, the measurement is taken, and a larger piece of the sclera is taken and trimmed initially roughly. Trimmed, and later the sclera is placed on the wound, and the eventual fashioning is done as you go on suturing. You can trim the remaining sclera. She's removing all the excess tissue and thinning out the scleral graft, then suturing the two ends. So again, it is important to cover this graft with conjunctiva, which she has taken from the inferior side, and then close the conjunctiva in both the places with the help of tissue glue or sutures. So I'll just forward this video. This is the conjunctival graft being prepared and then placed on the scleral graft, and she's closing it. Yes. So now scleral grafts in the cornea are rarely used unless you do not have any other option. So like shortage of cornea, so because it is an opaque tissue, so that is, you need to again tuck it in to prevent its extrusion and cover it with amniotic membrane. We have other alternatives which were explained by Dr. Kavita as well as Dr. Muscati. Now synthetic cornea would be where you need a replacement for the cornea, where other material is being used, either PMMA or a hydrophilic acrylic material, or even the collagen these days in newer modalities which are being used. Now they can be in the form of type 1, these are used usually in end stage cornea blind people. Important is we should not operate this patient unless both eyes are affected, and most often one eye is treated, the other eye is kept as a reserve. These surgeries have a high rate of post-op complications like infections and extrusion of these devices, retrocorneal membranes, and a high rate of glaucoma, many times combined with glaucoma shunt procedures, because even monitoring the IOP is difficult in these cases. So the type 1 K-Pro, where the eye is wet, and after indications would be for chronic cicatrizing conditions where the other eye is also not, the vision is not there, and where the eye surface is moist, and where the eye surface is keratinized and dry, then this will not do, and there we need to use either mucous membrane on the surface or the lid itself, like in modified OKP and this type 2 K-Pro. Okay. So these are the newer modalities of interest where bioengineered corneas are being used. I'll just touch upon this because it's interesting. So porcine corneas, where antigen removal is done, has been used. Also medical grade porcine dermal collagen, which is double cross-linked for strength, is a transparent hydrogel implanted into the stromal pocket, can be used instead of DALC for thickening the reinforcing the cornea. Also there are advancements like pure synthetic corneas which have been 3D printed. They should be glucose penetrable, and also possible problems here are again epithelial breakdown, ulceration, vascularization. Animal studies as well as early human studies are being done in blind eyes. Again, newer variants like this Clear, which is tucked into the stroma instead of a DALC procedure, and also the JK Pro. And the EndoArt is a flexible acrylic hydrophilic sheet which is replacing the endothelium instead of the endothelial keratoplasty. Also, in the COVID time, I remember using a BCL which was cut to place in the wound. We also had done that in a corneal the corneal melting after thermal injury for 2 to 3 days till we can get the graft. Yes, thank you very much.
Thank you, Dr. Suchi, for a wonderful presentation covering the last part of this topic. So, is the next session group already here? So we'd like to invite questions. We got the hall a little late, so we'll just take a few more minutes. So questions from anybody in the audience for any of the talks?
Yeah, so I had a question, Dr. Somasheila. In that case where it was shown, a scleral patch graft you did for that patient, I'm just thinking theoretically, is there any role of doing a Tennant's graft there?
Yeah, so many of these cases, many cases of grafts where I would either use corneal tissue or multi-layered AMG or sclera, I've converted now to using Tennant's patch graft in a majority of cases. And so one of the cases that Dr. Mascati showed, actually we put a Tennant's patch graft that was for the, I forget which one, either the Terrians or, so that failed the Tennant's patch graft, and that's why we had to use a corneal patch graft. But otherwise Tennant's patch graft, because it's easy, the tissue is available, and especially if it's a non-inflammatory condition, it's going to work extremely well. That's what we've seen. So most of the cases, and it's technically looks a little challenging, but it is not. So I think that should be the number one therapy for patch grafts, followed by the others. The second option for me, so now the sequence has changed. It's first Tennant's patch graft, and if I feel that is not going to work, or it's central, and we need something which will be like collagen, so eventually we'll at least have some, expect to have some vision, would be an amniotic membrane graft, a multi-layered maybe, or monolayered graft, and then followed by corneal tissue, and of course last would be sclera for any of these cases.
Also, Dr. Aziz, I'd like to add one point. Like, we have few cases in which the Tennant's was done for infective keratitis. So in those cases also, the infective keratitis meant only those in which the culture was proven and they were responding to the treatment. If they were not responding to the treatment, then TABCL versus therapeutic would be the option.
Yeah, that's a very good point. What Prajakta is trying to say, in other words, is that if you have active infection, then avoid doing Tennant's patch graft, because we're not very sure that this is a correct modality. And in active infection, I think most of us would use TABCL because of its antibacterial properties and how it prevents the infection from spreading.
And also in surface cases, we will prefer to do AMG rather than Tennant's for sealing the perforation, because we don't want to traumatize the patient's existing conjunctiva or tissues.
So the cases where we would avoid doing Tennant's patch graft would, Kavita, you have any response to that? Where would you avoid doing Tenon's patch graft?
I think in surface, yes, I agree with her. Definitely, amniotic membrane is a better choice. And in case it's a larger perforation where you feel multilayered AMG is not going to work because Tenon's does offer more tectonic support. So then maybe rather than doing a glue, and if you can't fit a BCLN like I had shown in my presentation, probably then Tenon's would have a role also in these cases. And definitely not do Tenon's would be when there's an active infection. I think she's already covered that. And that's why those two cases which you showed were relevant, because they were infections, but you waited till the TABCL was done, the infective component was almost gone, and you had an organism in hand. Patient was on antibiotic sensitive, antibiotic which he was sensitive to, and then you did the Tenon. So I think
Typically, these are the cases where OCP is there, where we do not want to disturb the local tissue there, as well as the ones where advanced glaucoma treatment is going on and the surface is poor, and we are saving the conjunctiva for further tubes or traps. So that is where we would not like to disturb and use the multi-layered AMG.
And Dr. Somasheila and Dr. Kavita, I have one doubt. Like, how would you toughen the Tenon's tissue, like in case we don't have the cornea? Can we use some cautery or some way to toughen it before placing it?
I've never done that. I think it just works well by itself. What about you, Dr. Somasheila?
I think that I understand the cases you're saying. If I have a bad neurotrophic keratitis, or even the patient that that Kavita showed, very prognosis-wise not a good case. So instead of Tenon's even, I would do a Gunderson's flap. So in effect, that's what you're asking, how to toughen it so that it covers it. So you do a conjunctival hood or a Gunderson's flap and sort of do a central tarsography and close the eye. But I wonder if you can do a multi-layered Tenon's patch graft.
Medical graft is what you're asking?
To strengthen it, is there any way we can reinforce it, like where we have a slightly larger opening on the defect?
So you want to place a Tenon's graft, over that you can place the amniotic and then suture.
So we can combine. You can also use glue, and then that glue won't work for a large perforation. So then you put Tenon's patch graft.
Some
that
people
would be
also
one.
use cyanoacrylate glue.
Yes,
So
in
you can
combination.
adhere it with the cyanoacrylate also. So that again.
So I think that if there are no questions from the audience, then we would please go ahead.
Experiencing sterile plus graft in scleromeningeal perforance. I have one graft, but recurrently the sterile is melting, even after grafting. Do you have any experience such?
So it depends on what was the indication in which it was
in
done.
Scleromeningeal perforance, that is.
So that is a
necrotic.
so that is an inflammatory condition. So it means that the immune suppression is not adequate. Systemic immune suppression is
Even
not
the
adequate.
eye is white.
Yeah.
White.
So classically, that's how they look. So they will look a little less inflamed, but they do need systemic treatment. So if that's proof for you that if the graft is melting despite the eye looking a little inactive, it means that the disease is still active. So that's a good point.
Okay. In that case, you have to combine the immunosuppression and graft.
Correct. So most of these cases, ideally, you can avoid doing a graft also. If the immunosuppression is adequate, you can just wait. Most of the time, the sclera heals fairly well. You may have a staphyloma, but that's tectonically stable. So not to be aggressive in these conditions. Thank you. So I think we'll thank everybody for patiently listening to us. And I would really like to thank for all my speakers for wonderful talks. And actually the session was put together by Dr. Prajakta. I just kind of took over. So I would like to thank Dr. Prajakta for putting together the entire course. And we thank AIOS as well. So with that, we end the session. Thank you very much. And we will take our group photograph, but of course everybody else welcome to leave.